Cytomegalovirus is a very formidable pathogen, especially in the transplant setting. It carries high morbidity and mortality, and involving other organs, it can involve the kidney also. So, in next 1 hour, we'll discuss the effects of cytomegalovirus in the transgraft. Women, CKD stage 5, diabetic nephropathy, living unrelated kidney transplantation, no DSAs, donor positive, recipe negative, CMV serology, ATG induction with TAC mycophenolate immunosuppression, valgal encephalitis prophylaxis for 3 months, and was doing well after transplant. Creatinine 1 and GFR of 80. 1 year later, presented with 2-week history of malaise, low-grade fever, nausea, vomiting, diarrhea, and weight loss, unremarkable physical examination, elevated creatinine, AKI, and admitted. Hemogram showed leukopenia and anemia. As usual, aggressive hydration was given, cultures were negative. And due to leukopenia, CMV was done, PCR was done, which showed copy of 32,58,977 copies. The serum creatinine continued to worsen, and a graft biopsy was done, glomerulitis and interstitial nephritis with positive CMV immunostaining. Along with that, an acute T-cell mediated rejection with the diagnosis of CMV nephropathy superadded TCMR. So in this background, we are going to discuss this infection which carries which is rare in the renal graft. The prevalence is to tune of only 0.2%. As a direct infection of renal graft, which causes CMV nephritis, is supposed to be very rare. Despite CMV infection and disease, relatively frequent in renal transplant patients. So short history, some trivia. The 1932 is it was first discussed in the purview of cytomegalic inclusion disease in children, and the renowned virologist Thomas Weller, who in fact had his Nobel Prize-winning virologist in 1954 for isolation of polio. He first isolated CMV from children with cytomegalic inclusion disease. So, as we all know, it's the herpes virus, the largest genome contains the largest genome of herpes viruses. It replicates only in human cells. It's a double-stranded linear DNA virus with hexagonal protein capsomeres surrounded by a lipid membrane. And it has direct as well as indirect effects. The direct effects are CMV syndrome or tissue-invasive CMV infection, CMV disease. CMV syndrome defined as the presence of detectable viral replication in blood, accompanied by symptoms and signs like fever, malaise, arthralgia, leukopenia, thrombocytopenia in the absence of tissue-invasive disease. But the threatening tissue-invasive CMV disease has clinical symptoms and signs of endogenous disease like enteritis, colitis, hepatitis, nephritis, pneumonitis, meningitis, encephalitis, and retinitis. And the indirect effects, again, it is general and transplant specific. General could be infections, either bacterial, fungal, or viral, PTLD or post-transplant lymphoma, cardiovascular events, NODAT, immunosenescence, acute rejection and loss of graft, and increased mortality. And specific to each transplant, there's an accelerated chronic allograft nephropathy or allograft loss after transplant, accelerated hepatitis C recurrence in liver transplant, hepatic artery thrombosis after liver transplant, a cardiac transplant, allograft vasculopathy, and post-lung transplant, bronchiolitis obliterans. And so what are the risk factors here? The most famous risk factor is donor CMV positive, recipe negative, blood products from CMV positive donors, anti-lymphocyte antibodies, prolonged or repeated courses of anti-lymphocyte preparations, acute rejections, sepsis, prolonged surgery, comorbid illnesses, and neutropenia, and the antimetabolite mycophenolate. So what is the prevalence here of CMV nephritis? So one of the largest retrospective biopsy reviews was in 2021 by Swanson. So it is all kidney transplant recipients and biopsy-proven CMV nephritis of around 10 years. At 6,490 kidney transplant recipients are reviewed. The incidence was only 0.2%. That is 13 biopsy-proven CMV nephritis cases. And the diagnosis median 7 months post-transplant. The pathology patterns of CMV glomerulitis in 7 out of 13 is 54%, and CMV tubulointerstitial nephritis in 6 out of 13, 46%. And median CMV DNA biopsy was 376,000 international units per annum. And most of the patients symptomatic, especially with GI symptoms like diarrhea, was the commonest symptoms in these patients. Even though they had renal failure, the commonest these patients had other tissue invasive effects also. This is from India. This was actually from PGI with Dr. Kusum Joshi's paper. 2,900 renal allograft biopsies over a 10-year period of only at 10 cases of CMV infection. And 7 out of 10 cases showed tubulointerstitial nephritis, CMV glomerulopathy without coexisting tubulointerstitial CMV. That's even CMV glomerulopathies was in 4 out of 1. It was 3 was coexisting with tubulointerstitial disease. That is cytopathy changes in glomerular endothelial cells and podocytes with a lack of significant inflammation, and one had CMV-induced TMA. These are isolated case reports, that is the de novo FSGS in 2 patients. It is published in JASN. And this is from Stanley Medical College, that CMV-induced collapsing glomerulopathy and necrotizing GN in a renal allograft recipient. This is isolated reports of even crescentic GN was reported in after along with positive CMV, which improved with treatment of CMV and reduced immunosuppression. How will you diagnose CMV nephritis? It occurs predominantly in immunosuppressed patients, renal transplant recipients, especially D plus R minus mismatch. Typically presents in 1 to 6 months post-transplant or after anti-rejection therapy. This time frame is changed, especially with universal. Most of the patients, especially high-risk patients, going on for prophylaxis. This important to differentiate disease from infection is because of the rapid progression which can happen with disease. The clinical features raising suspicion is unexplained rise in creatinine, constitutional symptoms, cytopenias, especially leukopenia, and recent immunosuppression intensification rejection therapy. Lab diagnosis, the first line systemic test is CMV PCR or quantitative NAT. The high viral load supports diagnosis, but it is not sufficient to confirm nephritis. But it's important for treatment monitoring, and renal biopsy is the gold standard in diagnosing CMV nephritis. The histopathological features, the presence of pathognomonic intranuclear and intercytoplasmic viral inclusion bodies within the infected renal cells, especially kidney cells, especially the tubular epithelial cells, and occasionally in endothelial cells or podocytes. There can be a patchy lymphoplasmacytic infiltrate with tubulitis, viral cytopathic changes with enlarged tubular epithelial cells and owl-type nuclear inclusions. And CMV immunostaining is a hallmark and it's a diagnostic clinging clinging feature. The characteristic electron microscopic morphology, a dense core and thick capsule may be present in nuclei and cytoplasm. This is an HND stain which shows large cells with basophilic enlarged nuclei and cytoplasmic inclusions within the tubular epithelial cells. This is again CMV nephritis with enlarged tubular epithelial cells with enlarged nuclei and degeneration. The classical owl-type nuclear inclusions. There is enlarged visceral epithelial cells and enlarged nuclei involving the glomerulus. Typical CMV glomerulitis. And this is the electron microscopy, the typical bullseye pattern of the virus in the cytoplasm. So again, another important feature of CMV nephritis, it can trigger acute cellular rejection in the kidney. Transplants through either it can with the multiple factors, including upregulation of HNA and costimulatory molecules, activates innate immune system, leading to a surge in inflammatory cytokines, T cell activation, and expansion of alloreactive T cells. There's endothelial inflammation, chemokine production, leading to recruitment of T cells, loss of Tregs, linked loss of tolerance, increased T cell injury, and increased donor, especially from the graft, increased donor antigen availability, and reduced immunosuppression with iatrogenic, especially antimetabolites are reduced, which enhances the rejection. So how do you distinguish between a graft biopsy in a TCMR versus CMV nephritis? So there's interstitial inflammation with moderate to severe tubulitis and endothelitis, especially the intimal involvement, the lymphocytic infiltrate in the arterial intima, which is specific for ACR, and there won't be any viral inclusions. Immunohistochemistry will be negative. While in CMV nephritis, there will be the classical owl-cell inclusion bodies, the plasma cell-rich interstitial infiltrate, the focal necrosis, the patchy inflammation. Although tubulitis is present, but generally not severe unless there is rejection associated. It can be associated with polyomavirus nephropathy as well. BKV can induce the CMV gene expression by stimulating the cellular regulated proteins by its own gene regulated proteins. It's not very common. One of the large number of patients was reported in this study by Park et al. There's a concurrent cytomegalovirus infection. The 4 out of the 10 polyomyvirus nephropathy patients are complicated by concurrent CMV infection. So, what are the prevention strategies here? This is like any CM infection, you have universal prophylaxis and preemptive therapy. You provide medication to all patients that are a subset of so-called at-risk patients. The duration of prophylaxis varies, could be from 3 to 12 months. It varies with the institution, varies with consultant, varies with the risk of patients and CMV status. And CMV anemia monitoring is not required while the patient is on prophylaxis. Mostly is with valganciclovir. Ganciclovir letermovir prophylaxis also has been taken, and optimal duration is 200 days versus 100. It's again vary, but then the studies have shown that 200, if the prolonged prophylaxis, especially 200 days prophylaxis, has shown a significant or statistically significant reduction in future CM infection while compared to 100 days therapy. The preemptive therapy is there is surveillance of CMV anemia in regular intervals, especially weekly, and initiate antiviral treatment at a pre-specified assay threshold. Advantages: selective drug use, potentially decreased drug cost and toxicities, and reduced rate of late CMV, but difficult to coordinate, especially delay in initiating therapy, the positive assays, and performing subsequent monitoring and management.
What is the preferred dose of CMV used in prophylaxis? So the most common mode, as is described, is around 450 milligram daily for 3 months is what is commonly practiced. Dr. Vinay, how would you give prophylaxis for a patient for CMV?
So, we follow prophylaxis for all the patients because we use induction agent. One thing that we do look into is those who receive IL-2 induction, we give it for 3 months. But those who receive T cell depleting, we give it for 6 months. One thing that we do look into is the GFR calculation also, we try to do it. So what is adequate for that dose? So usually we end up giving 450 milligrams OD. Very rarely only we have to end up giving 450 milligrams alternate day.
Okay. Duration is, as you said, for IL-2 it is 3 months, and
T cell depleting we give it for 6 months.
I think that is how do you manage leukopenia in such situations? Because they are already on antimetabolites as well.
The first drug is the MMF. MMF is always the culprit. So what we do is we kind of do a 50% reduction in the dose. Straight away we come down onto it. If you still face leukopenia, we'll pull out MMF. But the main aim is the CMV. It is the one that is causing the leukopenia. So despite taking out of MMF, you still face leukopenia. We'll do give GCSF, but continue the treatment.
By giving GCS, you try to maintain the valganciclovir.
Yes, we do. And if it is like a CMV disease, or if there is significant GI CMV disease where the absorption of Valgan, which binds with the albumin, if that is very poor, we end up giving IV ganciclovir for first 3 days at least.
So management, reduction of immunosuppression, especially test antimetabolites first, stop or reduce antimetabolites, and the CMV levels on the lower side, you reduce, and if at the higher levels, you'll stop the antimetabolite. Though the Victor trial is specifically showed that the double immunosuppressive therapy instead of triple and lower blood concentration of CNIs were significantly associated with eradication at 21 days of CMV anemia at 21 days. So another aspect is role of mTOR inhibitors here. The incidence of CMV infection disease is lower among patients receiving regimens containing mTOR inhibitors in kidney and heart transplant recipients. The Transform study, again, the incidence of CMV infection was lower in the everolimus group compared to the mycophenolate group. And some of the studies have shown the incidence as low as 0 to 10% in mTOR inhibitors group. So conversion from mycophenolate to mTOR inhibitor with reduced CNI, either later post-transplant or after a first episode of CMV infection or disease, Also reduce the recurrence of CMV infection in kidney transplant recipients. The potential benefits, either there's an antiviral effect, there's an improvement in T cell functionality, or there is a memory inhibition of select pathways involved in CMV replication. So how it alter the baseline immunosuppression? So how would you alter the baseline immunosuppression along with Van Gogh treatment? Stop antimetabolites, reduce cystoastatine, or reduce CNI?
Yeah, so we'll reduce the anti-metabolite straight away, at least straight away 50% reduction. But you're facing leukopenia, we'll just stop
Yes.
the MMF straight away because they are not going to reject because there's not much of sense. So we treat the CMV infection and then get them better, and then we decide on the immunosuppression further.
Very often, as a part of the disease, also there is leukopenia.
Yeah, so very true. So we take off the MMF, we keep a daily watch, do the daily counts, and we take it out.
And what about the dosing of valganciclovir or ganciclovir injections?
So ganciclovir injections, we go with to 5 milligram per kg IV, or valganciclovir, we usually give it 450 milligrams BD for about 3 weeks, and then continue it for another OD for 3 weeks.
Antiviral therapy, the first line of treatment is IV ganciclovir or oral valganciclovir, and second line is foscarnet or cidofovir. So the initial antiviral therapy is, especially in those with high viral loads or life-threatening illnesses, or those who are not able to take orally, ganciclovir 5 milligram per kilogram IV every 12 hours, and side effects leukopenia, thrombocytopenia, diarrhea are there. And valganciclovir is a DNA polymerase inhibitor which is orally administered, valine ester product of ganciclovir. It is as effective as IV ganciclovir for the treatment of post-CMV, post-organ transplant CMV, and it is well tolerated, has a similar tolerability profile as ganciclovir, devoid of adverse effects of ganciclovir. So as we can see here, this is where the antivirals act. The cidofovir and ganciclovir or valganciclovir act through the UL. It enters the cell to the UL97 kinase and gets phosphatized, and it acts on the CMV DNA polymerase. But cidofovir actually enters with through another mechanism, and foscarnet actually doesn't go to the nuclear. It doesn't act through the DNTP binding site, but instead it acts through the PPA binding site. So the resistant mechanisms are different, especially with cidofovir, ganciclovir, and foscarnet. So foscarnet is a pyrophosphate analog activating CMV both UL97 and UL54 mutations. And IV 60 milligram per kilogram every 8 hours or 90 milligram every 12 hours with dose adjustment for kidney function impairment. And it's highly nephrotoxic. You need hydrate pre and post infusion with close monitoring of electrolytes, creatinine, magnesium, and phosphorus. Maribavir is another oral drug which inhibits UL97 phosphotransferase and again active against CMV with UL97 and UL54 mutations. 400 milligram twice daily for 8 weeks. Non-bone marrow kidney toxicity and resistance has been reported. Interacts with CNIs and mTOR inhibitors. Cidofovir is another drug. It's highly nephrotoxic. Active against CMV with UL97 mutations, as we saw, but not against CMV with UL54 mutations. Dose at 1 milligram per kilogram 3 times a week as induction therapy, and then 5 milligram per kilogram every other week. You need aggressive hydration. Letermovir is not approved for independent use and might be used in low-level viremia or as a salvage therapy. And along with other drugs, leflunomide, arsenivate, anti-CMV immunoglobulin, and IVIG also has been tried. And how long to treat? The typical duration of therapy is 21 days and depends on the severity of disease and clinical and virologic response to treatment. And the general guideline is treat until both symptoms and CMV viremia have resolved, especially in 2 undetectable CMV PCRs drawn 1 week apart, often longer, especially for patients with tissue invasive disease, and you need to periodic monitoring for recurrence for high-risk patients.
Another important aspect is the occurrence of valganciclovir resistance, especially in patients who have had received prophylaxis. So when we treat CMV already in a patient who has had valganciclovir in the past, we're often confused on how to diagnose resistance. So what would be your practice in doing in assessing whether the patient has actually responded to valganciclovir?
So what we do is if the patient is with us, we usually try to monitor every week. We'll do the CMV viremia. Ideally, that is the best way to go forward. We monitor the CMV viremia and see if there is a log fall that is happening. Of all these, so far in this years, I've only seen about 3 patients who have not actually responded to ganciclovir or valganciclovir. We tried foscarnet, and surprisingly, after the old school drug leflunomide, when we gave it, responded. So, which is not a drug that is commonly used everywhere, but we here still continue to use leflunomide to handle CMV, viremia especially.
That most patients have already received valganciclovir for prophylaxis, and now the genetic testing is widely available. So when would you perform a genetic testing in CMV? Because in patients who have already received,
We have never done. So
okay,
there are a few late responders to treatment. So we have never done CMV. If you're trying to say you're targeting the gene, then that's the NUDT gene. If what you're trying to target, literature is very sparse, and in the Asian population, mainly it is done with those people who have azathioprine toxicity. But we have never done. We have seen very late responders happening after 3 weeks of treatment. Multi drugs, that is adding 1 or 2, can also combat the CMV viremia that we face. So we have never done, Binu.
most of the patients would have received prophylaxis in the initial part.
Yes, we do. So we give prophylaxis for every patients that we give, and that is what we are following. So our CME incidence, we only check after 6 months. We don't do it after 3 months because usually they tend to be negative. Unless and until in the first 3 months we have patients who have persistent leukopenia. We have seen only very few cases, less than 5%.
Yeah, okay. So the indications generally is either refractory or resistant CMV. Refractory means persistent viremia or disease more than 2 weeks and rising viral load while on therapy, and clinical progression despite therapeutic drug levels at a breakthrough CMV disease during prophylaxis. And resistant CMV is a viral genetic alteration that decreases susceptibility to one or more drugs. So somebody who is the CMV PC is rising, confirmed dosing and adherence, as is absorption is load, immunosuppression load, and start escalation with foscarnet or IV ganciclovir. If it's mild or moderate and severe, IV ganciclovir. You optimize immunosuppression and monitor weekly, and CMV PCR weekly. So if you say the UL97 mutation, that's most common, that's ganciclovir or valganciclovir resistance, cystifoscarnet or maribavir, and UL54, it may confer multi-drug resistance. You can use a combination therapy in severe cases, and foscarnet, or if susceptible maribavir. Cidofovir is supposed to be a last line drug, which is very nephrotoxic. And finally, the role for secondary prevention after an episode of treated CMVD anemia. So assess individual's risk after treating this patient, especially the CMV zero status, the recurrences, immunosuppression, and either you continue the treatment with valganciclovir, something like a secondary prophylaxis based on the risk, and where is available secondary prophylaxis with letermovir is also indicated if there is, especially if the patient is resistant to valganciclovir.
So how do you alter immunosuppression after an episode of CMV infection?
So after we have cleared the virus, since we do therapeutic drug monitoring, we are at a bit of an advantage. We keep a very low dose of anti-metabolite is what. So we keep the AUC bit about less than 30 nanograms. But before all this came, we used to switch to azathioprine and keep the patient on pred, cyclosporin and aza, or pred tac and aza is what we used to do.
Would you consider increasing immunosuppression because these are
No.
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 Okay.
Some of our patients are just on 2 drugs, pred and tac, as well, because we just can't add the antimetabolite or azathioprine. So we keep some patients, we keep the CNA a bit on the higher dose and keep the pred at around 7.5.
Summarize. So being a rare but significant complication with profound implications on allograft function and outcomes, it can coexist with rejection, and the diagnostic dilemma, especially it can cause rejection in other viral infections like BK polyomavirus, and can be a diagnostic dilemma sometimes. early identification treatment is imperative in ensuring this graft survival, especially at a high index of suspicion when you see a rising creatinine in a patient who is not on prophylaxis. Thank you.